Hello, my name is Dr. James Andrews. I'm an orthodontist and a former resident of the University of British Columbia in Vancouver. I am now practicing in Perth, Western Australia. Today, I would like to share with you an interesting case treated under the supervision of Dr. Ben Pliska and our Clinical Program Director, Dr. David Kennedy, for the How Would You Treat This Malocclusion section of the PCSO 2022 Winter Bulletin. The patient is an almost 13-year-old growing male who presented with a non-significant medical history. His chief complaint was he had proclined upper incisors and he was referred by his general dentist. With respect to the facial diagnosis, he had a convex profile with a brachycephalic facial type. The vertical thirds were within normal limits, but the horizontal fists, the chin and the nose were deviated mildly to the right. The nose was large with an obtuse nasolabial angle, and his lips were incompetent with an obvious lower lip trap. The labiomental fold was deep, and he had a pronounced chin button. The smile arc was non-consonant, and he showed about 90% of incisor display on full smiling. From the initial intraoral photographs, you can appreciate the Class 2, Division 1, Subdivision right malocclusion, with an overjet of 11 mm, proclined and protrusive upper incisors, retroclined and retrusive lower incisors. There was 100% overbite, which was impinging, and you can note the gingival recession on the palatal surfaces of the upper incisors. The tapered upper arch, there was an ovoid lower arch, and the upper midline was on with the facial, and the lower midline was 2 mm to the right. There was moderate upper spacing at 6 mm and mild lower crowding. With respect to the initial models, you can appreciate the full Class 2 molar relationship on the right and the Class 1 molar relationship on the left. The upper canines have recently erupted, and you can note also the mild asymmetry in the lower arch, combined with a very deep curve of spine. From the initial panoramic radiograph, you can appreciate there is a mild asymmetry in the condyles, the right one being mildly shorter than the left. The lower third molars were developing, and there seemed to be a vertical alveolar bone height discrepancy distal to the 2-2. From the patient's lateral cephalometric analysis, you can appreciate a skeletal Class 1 relationship with a mildly increased widths, a hypodivergent growth pattern, proclined and protrusive upper incisors, and a cervical vertebral maturation of CVM3. Which suggests the patient is entering their phase of peak mandibular growth. You can also appreciate the double lower border of the mandible, which may suggest some mandibular asymmetry. The following treatment options were offered. Fixed edgewise appliances combined with cervical pull headgear with a maxillary acrylic biplate. The second option was a unilateral carriere appliance with clear aligners. Our third option was a fixed Class 2 corrector, such as a forceps, or a mandibular anterior repositioning appliance, or a Herbst appliance with the unilateral activation on the right side combined with fixed edgewise appliances. If you are interested in how this case was treated, please go to the PCSO Bulletin 2022 Winter Edition. Thank you kindly for your attention.